Hi, everybody. It's Marylee Nunley with United Stroke Alliance. And this is the video version of our Facebook Live this afternoon. And I'm so happy to have as my guest, Beth Hoffman. And she's going to give a little introduction and give you her background. She is with Medtronic. And we're going to talk a little bit today about some of the secondary stroke risks and solutions. So Beth, can you introduce yourself, please?
Absolutely. Thank you, Marylee. Thank you for inviting me to speak to your group. As Marylee said, my name is Beth Hoffman. I am a physician assistant by training and have about 20 years of cardiology background, specifically in heart rhythm management. About 2 years ago, I came out of my clinical practice to join Medtronic as a medical safety professional. So really bringing the voice of the patients that I took care of to Medtronic and to the products that they are producing. And so it's been a really interesting, rewarding transition. And I look at myself as a patient safety advocate.
That was, advocate just came into my mind while you were talking. I'm like, she's a patient advocate.
Absolutely. Yeah.
Well, I think one of the things, and I think most people watching know that we started out doing camps for stroke survivors and their caregivers, and then we grew into Strikeout Strokes for stroke awareness and such. But one of the things that came to my rude awakening, because in the early years, people would talk about, I don't know why I had a stroke, don't know why I had a stroke. Often they were younger than what we think is typical for strokes. And when I understood the cryptogenic stroke, that was such a relief for so many people. And it kind of eased the angst of, I didn't do something wrong, it's not my fault type thing. So can you talk a little bit about secondary stroke? And I think AFib comes right along with that, but just give us a little conversation about secondary stroke and AFib and I guess the journey a person would take.
Sure. Well, I can tell you the patients that I took care of in my clinical practice, a big part of that was teaming up with the neurologists who were taking care of patients that had been admitted to the hospital with a stroke. And a large percentage of those patients didn't have a diagnosis for what caused the stroke. And part of their care pathway was implanting a small monitor, a cardiac monitor, and it was implanted so that they could leave the hospital and go about their lives while this monitor kept an eye on their heart rhythm. And the reason for that was such a large number of these strokes were caused by a heart rhythm abnormality called atrial fibrillation. And we've learned that many people do not feel atrial fibrillation. They're not aware of it. It runs the spectrum, because I used to have patients that could say, I went into atrial fibrillation at 4 o'clock yesterday. They knew exactly when it started. They did not feel well. They didn't tolerate. They couldn't function until we got them out of that rhythm. But a lot of people are unaware of it. And so if you are in atrial fibrillation, and I'm sure a lot of your viewers will know this, but the top part of the heart, instead of contracting the way it's supposed to, the top two chambers, the atria, will contract and squeeze blood into the bottom chambers, the ventricles. The top chambers are just shimmering. And that shimmering allows blood to pool, which allows a clot to form. And so often you can have atrial fibrillation, so you have that shimmering, the blood pooling, a clot forms, and that clot ends up going to the wrong part of the body, into the brain, causing a stroke. And so that's the role of atrial fibrillation in stroke. And once you identify atrial fibrillation, your doctors are able to treat you so that you don't develop another stroke. The whole goal is to prevent a secondary stroke. And people that have a stroke, 1 in 4 will go on to have a second stroke. So preventing that second stroke is very, very important. And that's where identifying AFib is so important.
So the reason that never would have come up when my husband had his stroke, he had a clot in his left carotid artery. He had been hospitalized for pancreatitis for quite some months, and his blood sugars had been very high, and he was diabetic. I was pretty sure that that was related to the event that he had had earlier in that year. So therefore, none of that came up to us because we had a clear diagnosis. So you're saying when there's not a clear diagnosis, this is a direction for a consult, at a minimum, a consult. So does the neurologist need to make this? Can a person, if a person doesn't have a neurologist, maybe using a PCP, could they ask for a cardiac evaluation? Talk to me about that.
Yeah, so as I mentioned, we had a relationship with our neurology colleagues in the hospital, and part of their stroke pathway was to make sure if they did not have a source of this stroke, they were going to recommend an implantable monitor. But there are a lot of people that maybe it was a minor stroke, they weren't really tied in with neurology, they were seen and discharged. And certainly talking with their primary care provider and talking about, what type of monitoring should we be looking at? Do we know why I had a stroke? And if not, is cardiac monitoring the right step? And the part of the value in this implantable cardiac monitor, I think we've talked about how tiny it is. It's very small. It gets almost injected underneath the skin and the chest. Part of the value is the fact that the battery lasts up to 4 years. Typically, you get an answer. If AFib is a part of the equation, you would typically get an answer. Sometimes it might take up to 3 months or so, and that's part of the reason why with a traditional monitor that you would wear, those monitors, maybe you wear it for 48 hours, you might wear it for 30 days. There are a lot of episodes of atrial fibrillation that don't get detected right away. So talking with your primary care provider about whether or not it makes sense is certainly reasonable.
So the referral came, and they felt like the implantable monitor was what they wanted. So I have the monitor in, and I go home and I'm doing fine. Who is watching what, and how will I hear about it?
Yeah, that's a great question. So the
big brother watching me.
Exactly. So the monitors, the patients are also able to communicate with a monitor that detects and kind of interrogates your implantable monitor on a regular basis, and it's looking for atrial arrhythmias, pauses, whatever it's been programmed to detect. It's looking for that every night. And if it detects something, it will send a message to, typically it's a cardiology clinic that has the monitoring service. It will send a message, a report, also some rhythm strips so they can see exactly what's going on with your heart rhythm. And if it's been your primary care provider that's been monitoring that or has been managing that, the cardiology clinic will typically communicate that to whomever has been kind of handling your care. And they'll make recommendations on what, go ahead.
Is there a device in the home? Okay, so because my husband has an ICD from heart failure.
Yep.
And so we have a little thing, it looks like almost like a telephone with a, so
at the bedside.
So you do have a little device.
You have a little device. You can also have, for people with smartphones, they can download an app that will actually, and so it's gotten easier and easier. And I understand that, the reluctance that, Big Brother's watching and that kind of stuff. But in this case, it's actually a really, really thoughtful, careful system that is keeping an eye out so that if and when they detect a rhythm, they're able to make recommendations in treatment that will hopefully help keep you safe going forward. So I understand.
Yeah, and my husband's had this monitor for over 6 years.
Sure.
And I don't have any issue whatsoever.
Good.
And we get notifications about fluids, and he's had a couple of little AFib type things. So they adjusted a medication.
Sure.
I feel very comfortable with it, very confident with it. And when they offered us 2 different brands of device, they had the Medtronic, and I can't remember what the other one was, and I just picked the Medtronic right away because I just have so much confidence. And it's not what the device you're talking about. Ours is a separate device, but I thought, oh, I know the people at Medtronic. I know they do a good job.
Yeah. Well, that's good to hear.
It was comfortable
Sure.
it gave me a confidence, you know.
Yeah. Yeah. Well, I'm really glad to hear that. And certainly there are professionals behind the scenes that are working very hard to help make people like your husband and you feel confident and safe.
Yeah. Even my chemo port for my breast cancer last year was a Medtronic device. So, I mean, I know they make all kinds of devices, but it's just kind of, it was kind of like, oh, I know them. I don't really, but the people I do know have been wonderful. So I guess I'm happy about that.
Yeah.
So anything else? I'm looking through my notes here, and boy, you have covered most of the things that I wanted to talk about. But I think we do want to let people know, since we're videoing this, you still have the ability to make comments. And so we would hope for you to make comments. And if there's questions, Beth's going to try and follow the video when it's on live. And I may be able to do that, or I may not, depending on what care my mother needs this afternoon. But then we will answer those questions, and we'll take a look in a day or so. And if there's any questions there, we'll just reply to your question. If you put a question in there, we'll reply to your question to answer any questions that you might have. So any last minute thoughts of anything we've overlooked, Beth?
No, not that I can think of. I just want people to know that if they don't feel like they have the answers that they need, you need to be your own advocate. Don't quietly go away and trust that everyone's got you covered. If you don't have the answers you need, press to get them. Have your family, your friends press to get the answers you need. So you have confidence that you're getting the care you need.
Absolutely. That is terrific advice. And I've learned many years ago to make good relationships with your doctors and your providers. And even if you're unhappy or you're frustrated, tone it down, do the best you can, do your research, but ask your questions, because healthcare has gotten complicated in recent years, the way everything is driven. So just keep asking those questions and reaching out. So, okay. Well, thank you so very much.
Thank you. It's my pleasure.
I love meeting you. And even though we weren't successful in doing it the way we wanted, we figured out a way to do it. So thank you so much for your patience and understanding.
My pleasure. All right, Marylee. Thanks, everyone.
Until next time. Thank you.
All right. Bye-bye.
Bye.